Good afternoon, everyone. It's right at 2 o'clock, so we'll go ahead and get started with today's webinar. My name is Larissa DeLuna with the American Heart Association Southwest Affiliate, and I'd like to welcome you to today's webinar on strokes in pregnant and postpartum populations. Before we get started, I want to go over a few housekeeping items. All phone lines have been placed on mute to avoid background noise. At the end of each section of the presentation, if you have a question, you can press *6 to unmute your line, or use the question and answer feature of WebEx in a question for us and for our speakers. Also, all slides and a recording of today's presentation will be available to everyone within 1 week. We'll be mailing that out. We will also be posting it to our website, www.heart.org/SWA quality. So for today, I'd like to turn it over to Laura Reese, the Manager of Hospital Accreditation Services for the American Heart Association's National Center. Laura?
As Larissa said, my name is Laura Reese. I'm the Accreditation Services Manager at the American Heart Association, and I am honored to introduce our first speaker this afternoon, Dr. Lee Pride. Pride is a professor of radiology and neurological surgery and interventional neuroradiology program director at UT Southwestern Medical Center in Dallas, Texas. Dr. Pride specializes in the treatment of hemorrhagic and ischemic stroke, cerebral aneurysms, AVMs, as well as other vascular abnormalities. He also serves as director of the UT Southwestern Fellowship Programs in Radiology and Neuroradiology. Pride earned his medical degree from the University of Alabama School of Medicine and completed residencies in neurology and diagnostic radiology at UT Southwestern. He received advanced training in neuroradiology and interventional neuroradiology through fellowships at UT Southwestern. I would like to welcome Dr. Pride and his colleagues this afternoon. Dr. Pride, I'll go ahead and turn it over to you.
Okay, everybody, we're excited that you're here for this webinar. To kind of run through, we have several people participating in this webinar. And sorry that I don't have such extensive introductions, but I'd like to introduce the colleagues of mine who are going to be participating in this. Dr. Mark Alberts, who's the professor and vice chair of the Department of Neurology and Neurotherapeutics here, and is just an excellent stroke neurologist with our program. Dr. Robin Novovich, who's one of my partners, associate professor in the Departments of Radiology, Neurology, and Neurotherapeutics. She's a neurointerventionalist and neurointensive care specialist here at UT Southwestern. Shivani Patel, who's an assistant professor in the Department of Obstetrics and Gynecology, who specializes in maternal fetal medicine, and then me, who you heard entirely too much about. So the way we're going to structure this is we're kind of organize this around a case, and we're going to have three topics that are pertinent to different phases of that case. So that's how we're going to try to structure this, and we want everybody at any point in time to just ask questions, use the chat line, use the digital means of asking questions, and we'll try to respond as best we can. After each stage, we'll have a discussion point, and it'd be best if you could hold those questions, the verbal ones, until those discussion points, and just do chat questions or the digital questions at any time. So this first case that we're going to present actually was one that drew interest of one of our local TV stations, and I think this is a really nice video
As we celebrate Mother's Day
to show.
One woman says she wouldn't be alive if not for her 3-year-old son. Health and wellness reporter Sonny Zod spoke to a young hero who jumped into action to save his pregnant mother's life.
For Linda Hernandez, these simple moments of motherhood are the most precious. There are moments she doesn't take for granted.
Oh, it was like a very sudden thing.
She merely didn't live to see them.
She was in a devastating neurologic condition when she came to us.
8 weeks pregnant, and Linda Lee became dizzy, falling to the bathroom floor.
And I tried to get out, but I couldn't. My body didn't respond.
Incoherent and barely conscious, she called for her 3-year-old son, James, who was in his room.
Who did you help? My mom.
James ran to his grandmother in the kitchen, who called 911.
How she presented, and this is how she came to us. She was 27 years old, really no significant past medical history except some hyperemesis gravidarum. She had last normal time that was that. She got to the ER very quickly within 54 minutes, and she found to have that head CT, which you can see shows a right dense MDA sign, and really no significant early stroke signs at all. There are her lab values. Glucose is normal. Blood pressure was basically normal. normal. So with presentation, we're going to lead into our first discussant, which is Dr. Alberts, who's going to kind of give us his impressions as to a neurologist's impression on stroke and pregnancy in this case in particular.
Well, thank you, Dr. Pride. Mostly patients who have strokes, they face a devastating neurologic deficit, especially at a young age. And being pregnant tends to complicate things, but it also helps to focus us on some specific etiologies. So oftentimes this is the treatment and diagnosis of stroke in a young person, since most people who are pregnant tend to be young. So if we go to the slide, okay. You can see this is looking at the epidemiology of stroke during pregnancy, and you can see from this epidemiologic slide that stroke in pregnancy does have some similarities in terms of strokes in general, in that they tend to occur more commonly in older folks. They tend to occur more commonly in African American folks. That's true for strokes in general, that stroke is largely a disease of aging, and it is more common in minorities, particularly African American folks. To the next slide, you can see that the type of stroke that somebody may have really varies significantly by the trimester that they're in. Now, in general, strokes are much more common in the third trimester, least common in the second trimester, which I think, as we'll hear from our obstetrician colleague, is sort of a quiet time in pregnancy, and then bumps up again in the first trimester. But it does vary significantly in terms of many more ischemic strokes in the third trimester, a few in the second trimester, and in terms of cerebral venous thrombosis, we tend to see a lot of that postpartum in the third trimester, and some subarachnoid hemorrhages scattered, but they tend to be a little bit more later than earlier in pregnancy. So this patient was obviously in her first trimester, and again, we'd be concerned about intracerebral hemorrhage, concerned about ischemic stroke, and frankly, I've seen more carotid dissections in the first and peripartum period because of all the pushing involved in labor. But we'll hear more about that in a few minutes. So this was a nice study published in OBGYN in September, about 10 years ago, and it looked at various risk factors and how they were associated with stroke in pregnancy. And listed them here by the most common in terms of odds ratios to the least common. So again, there's a lot of similarities between strokes in pregnancy and strokes in young people. So you can see a very powerful risk factor is migraine headaches, and migraines are very common in this age population. Whether you're pregnant or not, pregnancy can sometimes make migraines better or make migraines worse, but it is strongly associated with the risk of stroke, as is a thrombophilia or a clotting disorder, a typically hypercoagulable state, which is extremely common in pregnancy, particularly in the third trimester and then in the postpartum period. It's very strongly associated with strokes in and around pregnancy. Then underlying heart disease, actually in the literature, heart disease is fairly common in pregnant folks and is a very powerful risk factor, particularly producing cardioembolic strokes. Then you have a variety of diseases, sickle cell disease, hypertension, thrombocytopenia, which may be a marker for lupus, and then other typical vascular risk factors. So again, migraine, thrombophilia, lupus, heart disease, and sickle cell are things that we want to be on the lookout for in terms of risk factors. Stroke types vary significantly during pregnancy, and you can see in general the relative risk during pregnancy is higher for cerebral hemorrhage as opposed to cerebral infarction. Look at the relative risk in terms of during pregnancy versus in the 6 weeks postpartum. You can see that the relative risk of having a stroke jumps dramatically in the partum period, and this is true for cerebral infarction, and it is very true for cerebral hemorrhage. So even though this case is a young woman who's pregnant, we have to be very concerned and aware of the very high risk for stroke in the peripartum and especially the postpartum period. Indeed, the majority of women that I've seen with strokes are postpartum strokes, particularly for cerebral venous thrombosis. So this is a slide showing major types of strokes in pregnancy, and you can see we have ischemic strokes, which represent about half, and then we have cerebral hemorrhages, which represent a little bit less than half. This is much different than a normal population. In a normal population, i.e. a non-pregnant population of people 50 to 80 years old, ischemic strokes would account for maybe 80 or 85%, hemorrhagic strokes maybe 15%. Here, the numbers are much more balanced between ischemic and hemorrhagic stroke. You can see among the hemorrhagic strokes, we see a fair amount of patients who have intracerebral hemorrhage and a fair amount who have subarachnoid hemorrhage, more so than you would see in an older population. When we think about strokes in young people, yeah, we need to be concerned about ischemic strokes, but we need to be very concerned about cerebral hemorrhages, both intracerebral hemorrhage as well as subarachnoid hemorrhage. What I've listed here are some overlooked or underappreciated causes of strokes in pregnancy. These are conditions that I and my colleagues have seen fairly frequently, but may not be top of the mind for your run-of-the-mill practitioner. And they include a postpartum cardiomyopathy as a cause of cardioembolic strokes, a postpartum CNS vasculitis, which can oftentimes present with headaches, seizures, and focal neurologic symptoms, embolization of amniotic fluid, which would occur actually during delivery, with paradoxical embolizations, typically if they have a DVT, and keep in mind that the clot may not just be in their legs, it may be in the deep pelvis, as you'll hear from Dr. Fetal in a few minutes, and have to have a right-to-left shunt to get across the PFO. Arterial dissections during labor and dissections during the beginning of pregnancy, where you have hyperemesis type syndrome. I've seen that fairly commonly from a lot of pushing during labor, causing oftentimes bilateral carotid-vertebral dissections, as well as bilateral dissections from a lot of nausea and vomiting earlier in pregnancy. So these are some of the things that I've seen in my few years of practice. So I talked about a few minutes ago, causes of stroke in pregnancy largely mirror causes of stroke in young people because most of these already are young people. So things that we consider include cardiac etiologies, such as endocarditis, even with negative blood cultures, papillary fibroelastomas, atrial myxomas, as well as PFA, arterial dissections, as we were just talking about, CNS vasculitis, hypercoagulable states in the setting of pregnancy and or cancer, but pregnancy does make you very hypercoagulable and causing venous thrombosis, metabolic disorders, infections, HIV, CNS infections, syphilis, headaches, which as we talked about before is in and of itself a very powerful risk factor for stroke, especially if patients are above the age of 30 or 35, and if folks were smokers, and if they had been using oral contraceptives. And I would remind you, as I'm sure Dr. Patel can appreciate, that being pregnant is like taking a whole lot of oral contraceptives because you have a lot of high hormone levels. Pregnancy, as we've been talking about, and then drug abuse. Do not get drug abuse, even though, you know, we want anybody to abuse drugs, especially during pregnancy. We know that this can happen, especially with marijuana, cocaine, and methamphetamine, and they have rare genetic disorders like CADASIL, carousel, MELAS, and the like. Studies are there, and this was a recent study published in Neurology just a couple years ago. This looked at inpatients, the national inpatient sample from 2005 to 2010. They actually found over 18,000 pregnant patients who had stroke, which was a pretty high number. They found 27% of them were due to cerebral venous thrombosis, in one of the major venous channels in the brain. And 3% of these folks had an intracerebral hemorrhage or a subarachnoid hemorrhage. So these are much higher numbers. This is a much different disease profile than we would see in a typical stroke population, where cerebral venous thrombosis at most would be 5%, and hemorrhagic strokes would be about 15%. So again, pregnancy does increase your risk of having particular subtypes of strokes. Now, out of this sample, they did report that 70 patients were treated with IV TPA, and out of those, almost 80% were able to be discharged home, which is good. 40% were left with a major deficit and went to a nursing home, and 7% of this group expired or died. Actually, is pretty high considering we're talking about a relatively young, healthy group here with a 7% mortality rate. The question always comes up in pregnancy, and as this patient presented, and as we'll hear about in a minute, what about using TPA in pregnancy. Dr. Ginsert says it's not necessarily a good idea, but it's not a firm contraindication. What we tell from the literature, what I was able to find the largest case series was about 8 patients. Found that most of the strokes, the ischemic strokes, were due to cardioembolism or a hypercoagulable state. The duration of the pregnancy when the patient had the stroke varied. Out of 8 patients, 4 of them were very early, 4 to 6 weeks. 2 of them were relatively early, 8 to 10 weeks. One was at 12 weeks, and one of them was quite late at 37 weeks. The outcomes, however, were not so good. See that in 6 of the 8 cases, or 3/4 of the cases, the pregnancy was terminated, there was fetal death, or a miscarriage. In terms of the mother's outcome, in 3 out of the 8 cases, some types of cerebral hemorrhage were reported. So again, small case series, but it does point out some of the risks as well as benefits of using IV-TPA early in pregnancy. We'll talk more about this in just a few minutes. Now, what about endovascular therapy for strokes in pregnancy? It's supported by small case reports and case series, and we'll hear more about this in a minute. But just looking at the big picture, from my point of view, I think endovascular therapy has some advantages. It's very focal. You don't have to give systemic TPA. It's targeted and clot-specific. The new devices, the stent retrievers, appear to be very safe and very effective, and you avoid the systemic effects of using TPA and other agents. There are some disadvantages, though. Obviously, vascular therapy is an invasive therapy. There's exposure to radiation. Often the patients need to be sedated or require general anesthesia, and there are bleeding risks. Some case series have shown 2 to 5% risk of subarachnoid hemorrhage related to endovascular therapy. There is no free lunch. So in conclusion, let me say that strokes related to pregnancy are often due to unique etiologies that differ from a typical older population. The evaluation of patients with strokes during pregnancy sometimes requires special testing. The use of IV-TPA in this population is likely associated with an increased risk of bleeding and fetal loss. Endovascular therapy is an option in certain centers, but many places do not offer this therapy. At the end of the day, you really need a multidisciplinary team approach to ensure optimal outcomes for the patient and her baby. Thank you very much, and I'm going to turn this now over back to Dr. Pride.
This is an opportunity for a discussion, and we'd like to take some questions from any of the participants. And I have to say that I need a little bit of technical help because I'm not sure we're seeing our appropriate digital questions. Are there any questions from the group regarding our first stage of this case presentation or the first talk?
I have questions in the online queue, but if anyone would like to come off mute with *6, happy to start a conversation.
Well, no one has a question about this. I do have sort of one question, and that is, in the decision about giving IV-TPA to a pregnant patient, are there conditions of the stage of pregnancy that would be important to you, whether later or earlier in pregnancy, about choosing to give IV-TPA?
So I'm Dr. Patel for a consult, but in my experience and in my opinion, I think early is probably safer than later, especially if someone's in pregnancy having some spotting or bleeding. That would make me very nervous. But Dr. Patel, what do you think?
Yeah, what Dr. Albert said is absolutely correct. You really have to consider what stage of pregnancy are you at. And, you know, one of the things lines that we as obstetricians think about is that point of viability. And for us, it's in most across the country, it's about 24 weeks. And so when we look at treating women who are pregnant with disease and with strokes is prior to 24 weeks or are they beyond that point? And prior to 24 weeks, we almost just say treat them as if they were pregnant. So because there's nothing that you could actually do to potentially intervene for the baby at that point. And so you don't want to end up with a poor maternal outcome just because of a fear of what could happen to the baby when you're talking prior to 24 weeks. So I agree that I think if you're prior to 24 weeks and early in the pregnancy, IV-TPA is definitely a reasonable option, something to consider. And if you're later on in that 3rd trimester and there are other symptoms like spotting or she's contracting or potentially is she in early labor, that may not be the optimal time to use IV-TPA.
And one question, we'll move on. Are there any, can you all think of any particular informed consent issues that primary practitioners or practitioners who might be listening would need to with IV TPA administration in a pregnant patient? Anything so about that?
Sure. So I think one thing that has to be made very clear is that there is a risk for loss of the pregnancy, and that baby may not make it, or that fetus may not survive, whether it's in miscarriage at 8 weeks or what we consider possibly a fetal demise between that 20 and 24-week mark. And so that has to be made very clear, and that risk, I think, definitely needs to be addressed with the patient and family or whoever is participating in that consent process.
Yeah, I would agree. Getting informed consent for anybody getting IV TPA, but especially a pregnant person, would be very important so that there's a clear understanding of the risks and benefits of that therapy.
There's questions in the question and answer part of WebEx. Are you able to see those, or would you like me to address them? Or
tell me how I get to that. Where is that?
up in that same top bar that we've been using, drop down to the right. There's an arrow for a drop down.
Yes. Got it. And I go to what part?
Q&A. Should be first thing listed at the top.
Oh, got it.
Yes.
Okay. What blood thinners would be best to use after 24 weeks for patients going to IR procedures? Sedation, etc. So this question is directed more towards the intraprocedural aspect of being a pregnant patient, and oftentimes we don't give much in the way of blood thinners during one of these stroke interventional cases. Sometimes we give a small dose of heparin, and I think that's what I would use. Robin, do you have any thought on that blood thinner during the interventional procedure? Use heparin, a dose of about 1,500 or 2,000 units, followed by 500 an hour.
Correct. That would be the same that I would use during a procedure. And heparin used during pregnancy is actually pretty safe, correct?
Correct. So the only real true blood thinner that we try to stay away from is coumadin, and even that we use in a small subset of population after we reach that first trimester. But heparin is completely safe in pregnancy, and we use that frequently.
Dr. Wright, do you sometimes give a little squirt of TPA directly into the clot, or do you not do that anymore?
Often not now. We're typically using just mechanical agents first. Yeah, we use the little TPA if it's a distal embolus most of the time. What we'll do for that. So is there a question there? I see just one.
There's a couple of more. You might scroll up.
Oh, in the interest of time, if a pregnancy is terminated or miscarriage, etc., how soon after the TPA administration would this occur? That's a good. Any thought about that?
After the TPA. TPA is going to have its maximum thrombolytic effect in just a few minutes, although it can have an anticoagulant effect for about 24 hours. Say the time of major risk would be probably 24 hours, but again, I would defer to Dr. Patel. I would imagine you'd want to do ultrasounds and see what's going on with the fetus and the placenta, because some case reports have shown intrauterine hematomas.
Correct.
TPA.
Correct. So that risk of bleeding, I think, is maximum at 24 hours. It could be possible that a small placental bleed started in the time period, and the placenta kind of exacerbates itself. The uterus is very sensitive to any bleeding, and sometimes it kind of turns into a cycle that you can't get out. A little bit of bleeding that was caused potentially by the TPA irritates the uterus, it contracts, causes more bleeding, and now the bleeding is actually not from the TPA that was administered 2 or 3 days ago, potentially just irritability of the uterus.
One more question here, but in the interest of time, I think we're going to answer that question as we go on. It's how would you best manage a patient without using TPA? So I'm going to return to the case, and we'll answer some questions as we go along. Let's see, I need to get on the slide here. So turning to the case, we'll talk about some large vessel occlusion management decisions, because this clearly was suggestive of a middle cerebral occlusion with a dense MCA sign. So a decision was made in our case, give IV TPA at the primary stroke center, which was given in an hour and 53 minutes. No vascular imaging was done there. There was no immediate improvement after IV TPA was given. She transferred to our comprehensive stroke center here. It took a little under an hour to get here. She deteriorated en route. Her stroke scale went from a 10 to a 19. Again, no vascular imaging was done at the outside center. Now we're at 2 hours and 56 minutes into her stroke, and the question is, what should we do now? Should we proceed to intervention? What sort of imaging should we do? And I'm going to introduce Dr. Robin Novakovic to give a talk on the neurointerventionalist perspective.
Thank you, Lee. So over the past 10 years, the use of radiologic examination in pregnant women has actually increased by 107%. Radiation, of course, is the invisible threat in our endovascular interventions or in any radiologic exam a patient might get. The interventionalist thus has the role of overseeing the radiation protection, not only of the staff and of the patient, but in these cases of pregnant patients, we have to be concerned about the fetus. We also have to determine the appropriateness of performing the endovascular procedure to treat the patient, as well as decide what diagnostic studies we want to undertake. So currently, the dose to the baby is not subject to legal dose limits, but we are guided by recommendation and current evidence that is out there. This topic, I want to differentiate between the two types of radiation. We have ionizing radiation, which we see in X-rays and gamma knife procedures, as well as the CT scans and the studies we have performing endovascular procedures. And there's non-ionizing radiation, which you see with electromagnetic fields, microwave radiation, and even ultrasound. So if we're going to focus on ionizing radiation during pregnancy, but it's important to keep in mind that a fetus will be exposed to about 1 milligray of background ionizing radiation during pregnancy, and this is even in absence of having any radiological exam. There are really two main damaging effects from ionizing radiation. We break them down into deterministic or threshold effects and stochastic effect. So the threshold effect is where it's a result of damage to a number of cells. The dose threshold before damage occurs. So this includes things like malformation, mental retardation, and even death. There's no effect expected below a dose of 100 milligray. Now, the stochastic effect, the result really comes about from damage to a single cell, and it can lead to carcinogenesis. There's no absolute dose threshold with this type of effect, but the rise of rising dose may actually, the risk of damage increases the radiation dose. However, the severity of the effect really remains the same. So if someone develops leukemia, it's not going to be a more severe case of leukemia if they should develop it. Just for a little bit of background, as we're going to be talking about in this portion, there's different ways to measure radiation dose. And absorbed dose is measured in the rad, and the effective dose is measured in the rem. In the International System of Unit, the rad is measured as the gray, and M is measured as the sievert. And so 1 rad is equal to 10 milligray. And I'm going to try and put everything in the milligray scale so that you'll kind of get a better understanding of dose that patients will receive in endovascular procedures. So the vulnerable stage of the embryo to teratogenesis is between the 2nd and 20th week of gestation, particularly the period between the 8th and 15th week when they have more fetal organ formation. In the 2007 recommendation, the International Committee of Radiologic Protection concluded that no threshold effect of particular significance would be expected to occur below a dose of 100 milligray. At a radiation dose exposure less than 50 milligray, the fetus at all stages of gestation generally suffers no major developmental abnormalities. The risk of a fetus ionizing radiation is really dependent on the gestational age at the time of exposure and the dose. Extremely high dose exposure occurs during early embryogenesis, then it is most likely to be lethal to the embryo. In humans, growth restriction, microcephaly, and intellectual disability are the most common adverse effects from high-dose radiation exposure. In the data from the atomic bomb survivors, it appears that the risk of central nervous system effects is greater with exposure at 8 to 15 weeks of gestation. It has been suggested that minimal threshold for this adverse effect may be in the range of 60 to 310 milligray. However, the lowest clinical documented dose to produce severe intellectual disability was actually at 610 milligrams, so a pretty high dose. Fetal risk of anomalies, growth restriction, or even spontaneous abortion have not been reported with radiation exposures of less than 50 milligrams, a level of the range of exposure for diagnostic procedures. In this table, you can see that radiation or exposure from a head CT or neck CT can be a fetal dose of 1 to 10 milligrams. Risk of carcinogenesis as the result of intrauterine exposure to ionizing radiation is unclear, but probably very small. 10 to 20 milligram fetal exposure may increase the risk of leukemia by a factor of about 1.5 to 2 over a background rate of approximately 1 in 3,000. With larger doses, the risk increases approximately by a factor of 2, but keep in mind the overall risk is still very low. Should a pregnant woman need to undergo multiple imaging studies, then it would be prudent to consult a radiation physicist to calculate the total dose expected, as well as the dose that's ultimately received to the fetus. There is a Health Physics Society that makes a website that has an Ask the Expert feature that can be a source of further questions or answers if you want to look at this website. In counseling patients regarding the risk of radiation exposure to their fetus, these should be balanced with the potential for benefit. And that is something with endovascular procedures that we always have to try and keep in mind is will the patient potentially benefit from the endovascular procedure and warrant the risk to the patient and fetus. If necessary to use radiation during pregnancy, a risk assessment should be conducted, referencing both the gestational age at the time of exposure, the extent to which the fetus is included in the radiation field, and the radiation level that's received. Such dose will a patient receive in some of our procedures. There isn't a lot to guide us in the literature regarding thrombectomy or endovascular revascularization, so we have to look first at one of the more common procedures and symptoms that patients will have, which is the pulmonary embolus. So it reports in the literature that a pregnant woman who undergoes a chest X-ray, a CT with pulmonary angiography, as well as a pulmonary angiography, the combined exposure to the fetus would be about 1.5 milligram of radiation. And this is very low compared to the 50 to 100 that we know is the safety level. According to the American College of Obstetrics and Gynecology, their guideline statement is that the radiation dose to an embryo or fetus that is likely to result from any diagnostic procedure in current use should present no risk of fetal death, malformation, growth retardation, or impairment of mental development. So things that we can do to protect the fetus further. And so in this particular study, they looked at letting the uterus or the abdomen in these patients that are going on to have x-rays or even procedures. And in this study, the patients were having a CT for a pulmonary embolus, and they did the abdomen in these cases, and they found an increasing thickness of the lead decreased radiation dose to the uterus, as well as increasing the proportion of the patient that was covered by the lead shield. So further that we can do to try and lower the dose to the fetus. There was one report at a conference where they looked at what the exposure of the fetus was in another endovascular procedure where they were coiling an aneurysm. And the dose measured over the uterus during this procedure was 11 milligram, which is equal to 0.11 milligram. And that was with letting both the front and back of the patient's abdomen. Now look at something that has a very large radiation dose. How much will the patient actually receive? So I looked at a gamma knife surgery article where they show the patient receiving 20,000 milligram directed at a brain tumor. These patients, one that was pregnant as well as 20 other consecutive patients, they found that the overall dose to the uterus was pretty low. So it was about 3 to 1.5 milligram looking at different areas of the uterus. So again, well below that threshold that we need to be concerned about. So what about during our procedures? Well, at least in our institution, for the last few procedures for thrombectomy that we performed, had a mean radiation dose exposure to the patient of 1,148 milligray with a wide range between 650 to 1951. And at various CT scans and CT angiograms and CT perfusions, you can see that dose is actually lower than that you would receive during a CT angiogram or even a CT perfusion that can be as high as 2,600. And keep in mind that these exposures translate to a dose to the patient, or to the fetus, in a head CT, for instance, of 1 to 10 milligray, even though the mother is being exposed to a dose of about 1,200. So the American College of Radiology concluded in 2015 Manual of Contrast Media that there is no evidence of either mutagenic or teratogenic effects secondary to IV or IA contrast exposure during pregnancy. So even the FDA supports this with their classification of a category B for the medication. So iodine contrast can cross the placenta either into the fetal circulation or pass directly into the amniotic fluid. Animal studies have reported no teratogenic or mutagenic effects from its use. In the interest of time, I'm going to skip ahead, but currently given current available data and routine evaluation of all newborns for congenital hypothyroidism, there really is no need to test any further. There does not appear to be an effect of hypothyroidism in neonates following administration of IV contrast or IA contrast in a mother. Because contrast is water-soluble, less than 1% of iodine contrast administered to a lactating woman is excreted into the breast milk, and less than 1% of that amount of contrast will be absorbed through an infant's tract. So currently, breastfeeding can be continued without interruption after the use of iodinated contrast. So there's no threshold effect for practical significance would be expected to occur below a dose of 100 milligray. And you can see that our procedures, as well as those of CT scans, would be well below that threshold. The radiation dose to the embryo of fetus that is likely to result in any diagnostic procedure in current use should present no risk of fetal death, malformation, growth retardation, or impairment of mental development. Breastfeeding can be continued without interruption. So should a pregnant woman need to undergo multiple imaging studies using ionizing radiation, it's prudent to consult with a radiation physicist to calculate the total dose expected and to receive to the fetus. And here again is that website that could be a good source of reference to physicians as well as patients. And I also want to make one other note that in the guidelines it was stated that at no point should it be considered to counsel a patient that they should abort a pregnancy based on any radiation dose exposure.
So another point of discussion and questions, and I'm just going to check and see if we have any new questions. It looks like we don't have any. Are there any oral questions anyone would like to ask?
6 to come off mute if you'd like to ask the question.
I see a new question about using TPA in the postpartum, and I think we might hold that for the last discussion session when we're talking about after this case. So we'll hold that one. Are there any other questions? We can move on in the interest of time. And so one of the considerations for us here, as we've heard from this great lecture, is that the woman's, at least her functional outcome is obviously threatened by this severe stroke. And as we've heard from the radiation exposure, it probably isn't something that we substantially need to worry about. But we do need to counsel the patient on that. So we're going to move on to the case presentation. And I just have a question to ask. We have this patient. I'm going to go back to the case presentation here and where we are. And so in this large vessel occlusion in pregnancy that got IV TPA, who is at a very high stroke scale score and has what appears to be a right middle cerebral occlusion with no vascular imaging, is there an opinion of the group where we should proceed with non-invasive vascular imaging that might involve some time expense or some radiation expense, or would the group feel like maybe we should just move on with the data that we have to a type of intervention at this point? Any thoughts?
Well, she had a CTA.
She's not had a CTA. And we're talking about the extra radiation from a CTA. She just got a large vessel suction from a dense MCA son.
Yeah. What we've heard from Dr. Novakovic is that the risk of the radiation, in contrast, is really minimal, and we know from experience that not everybody with that hyperdense MCA sign really has a clot or occlusion there. I would favor doing vascular imaging. It's quick, it's safe, and it could provide valuable information and help you and your colleagues plan the intervention.
Yeah.
I would vote for imaging.
You know, in this case, I think that I might opt to go just to angio. I do hear what Dr. Alberts is saying, and I think that it is wise to get CT angiogram in the majority of our patients. But in the sudden onset of hyperdense MCA, to limit for radiation exposure, I would probably be willing to take the patient to the endovascular suite.
So we'll split on that. So we'll go to what we did in the case, and I'm having trouble having this go forward. So what we did, here's the repeat CT scan that was done at our institution, and you can see that there hasn't been any progression of stroke. She's in the same clinical state. We made a decision because of her severe deficit and the dense MCA sign and the high likelihood of having a large vessel occlusion, not to waste the time, contrast, or radiation of a CTA, and we took her directly to the angio suite to save the time. You can see there we're at 3 hours and 10 minutes. This is what we found when we got to the angio suite. I'm not sure why this is not going forward. There it goes. There was a carotid occlusion on the right that you can see in the two images on the left, and we studied the left carotid to look at her collateral flow, and there was good collateral flow to her hemisphere. We got a catheter across the occluded carotid lesion, the intracranial occlusion, and the image on the left, you can see a catheter across the long clot extending from the supraclinoid carotid into the MCA. And we deployed a stent retriever that's in place right here by 4 hours after her stroke onset. In one pass with local aspiration and a stent retriever, we got TICI-3 flow, so we had her open within 4 hours and 7 minutes with a radiation output from the tube of 1133 milligray. Now that's what the tube puts out to look to the head. It would be, as we've heard, much lower to the abdomen or fetus. And then the contrast amount we used during the procedure was 125 cc's of IsoView. She got better within about 4 hours, improved from an NIH stroke scale of 19 to 4. You can see there was a little spasm in her MCA after we pulled the stent retriever out. And by the next day, she'd actually gotten to an NIH stroke scale of 2. The spasm in her MCA had resolved. And by the afternoon of the next day, 27 hours and 30 minutes after her onset, she had returned to normal. Here's an MRI scan that she got done the next day. You can see some ischemic changes in the temporal lobe and in the deep white matter. In the ADC, it looked like most of those that were actually infarcted were just in the deep gray matter and deep basal ganglia region rather than the temporal lobes. So she returned to normal and she was discharged within 4 days. I have another video.
Fast. Doctors performed endovascular therapy. This is what doctors used to remove the clot. They threaded it through Linda Lee's body, her heart, and into her brain before pulling the blockage from her blood vessels. Linda Lee's recovery surprised even doctors.
In 4 hours, she was essentially able to walk. And in 4 days, she went home.
If it wasn't for him, Mom, I probably wouldn't be here.
At home with her healthy 4-month-old miracle baby, Alyssa, Linda embraces the moments between her son and daughter. Jay tells Mom he wants to be a fireman.
When I grow up, then I'm going to bring a big for the
A career that helps people. Not surprising, because Jaden has already saved a life.
And how does that make you feel? Happy? Say why? Because if somebody needs help, then if they call my name,
Sonia, Channel 2.
And so to talk about the workup that we did after her stroke to try and get at the etiology, I'll have to say we never got at a firm etiology, but we did a very complete workup. She was treated with aspirin, started 24 hours after the IV TPA, and sub-Q heparin for DVT prophylaxis. The only potential etiology we found was on a transthoracic echo that showed some apical color flow possible on only one view that suggested the possibility of a small patent foramen ovale. Everything else was basically normal. She did well through her pregnancy, had normal fetal ultrasound exams, complete hypercoagulable workup is all negative. We never really came up with anything else, including looking for a significant cardiac arrhythmia. She had searches for leg and pelvic DVTs twice during her pregnancy, and none were found. And she had a normal vaginal delivery in December on aspirin. And so I'd like to lead into our OB-GYN perspective from Dr. Patel, and I'll just have Dr. Patel take it away.
So when we consider looking at the obstetric perspective of this case, or really any case, we kind of have to think about the implications of pregnancy, and then also when we consider risks and therapeutics and outcomes, we look at maternal perspective and a fetal perspective. So chances of a pregnant woman having a stroke, and some of this Dr. Alberts has kind of already gone through, but I kind of want to highlight that mortality from stroke is still very high, and 10% of those patients are not discharged home. They end up in another facility, which can be hard for a young person, a young family. She might have other children at home, and so those are all things that go into consideration when you're sending someone not home into another facility. But the biggest point here, I think, is to note is that the breakdown of when strokes happen in pregnancy is very clear, and about 10% happen in antepartum period during the course of pregnancy, with 40% intrapartum or during the actual labor process, and half of them, 50%, in that postpartum period. When we look at what are actually some risk factors specific to pregnancy alone that increase a woman's risk of stroke, one of the first things we have to consider is this thrombogenic state or increased risk of clots. That's due to the increased levels of estrogen, and those estrogen levels rise starting in that first trimester, and they become very high. And that increases all clotting factors in general, but more particularly we see an imbalance in that we see more an increase in procoagulant factors versus anticoagulant factors, leading to a thrombogenic state. Out of Williams obstetrics, and clearly you see elevated fibrinogen, factor 7, and factor 10 levels, and actually a drop in normal TPA that's in the circulating system, and a drop in protein C and protein S. And so those levels together lead to this increased thrombogenic state that makes pregnant women a higher risk for thromboembolism. Additionally, have a large gravid uterus, and this really starts to take effect in the latter second to third trimester, where that gravid uterus compresses on those pelvic veins. And when you compress those pelvic veins, you get venous stasis in the lower part of the body. That leads and promotes to clots that can form in either the pelvic veins or in the deep veins of the lower extremities. So when we think to look for clots, most of us immediately go to the lower extremities, but if that's negative, you also really need to consider looking at the pelvic veins, and is there a clot in the pelvic vein that a simple ultrasound of the lower extremities is not going to identify. And then other specific factors to pregnancy alone, the biggest one is hypertension, and hypertension complicates 5 to 10% of pregnancies. As our population becomes more obese, diabetes becomes more prominent, so does hypertension. And we're seeing more and more women, even young women, with hypertension. And this kind of goes back to what Dr. Alberts was saying about the increased risk of stroke in the third trimester. That's where we see gestational hypertension show up. That's where we see preeclampsia show up. And that's also why we see a large increase in hemorrhagic strokes. It's because most of those hemorrhagic strokes are in women who are hypertensive. And so that's something definitely to take into account. Hemorrhage. Obstetrics hemorrhage is real, and it can be dramatic. And just losing over 500 cc's from a vaginal delivery is considered hemorrhage, or over 1,000 cc's at the time of a C-section, and that's women at higher risk for stroke. And then a cesarean section. Any kind of surgery is traumatic. There's decreased mobilization, and so that puts women at higher risk for stroke. And the C-section rate across the country currently is 30%, which is incredibly high. And so it's not surprising that we're seeing other comorbidities, including stroke. Other risk factors, and so this is from the same, a source similar to what Dr. Alberts used from Obstetrics and Gynecology, was published about 10 years ago. And these are just odd ratios looking at factors specific to pregnancy. So hypertension is about 4.4, estrogen, ratio is about 2. The highest blood transfusions at about 10.3 related to postpartum hemorrhage, and then postpartum infection, which has a risk ratio for stroke, but we don't actually see it that commonly in the postpartum period. And then types of stroke, again, hemorrhagic, all strokes increase at postpartum period, and so hemorrhagic stroke and ischemic stroke both accompany, you see most of that in that postpartum period, because mostly of that hypertension and increase in thrombogenic factors in that large gravid uterus. And this is just kind of reiterates the idea that imaging in pregnancy really should not be withheld just because a woman is pregnant, that the vast majority of the effects that we see are really not related to the actual imaging studies that are done. Before pre-implantation, the estimated threshold of 50 to 100 milligrade can potentially cause death of the embryo or no consequences. It's called what we call the all or nothing effect. And it's hard at that point to even say that it's attributed to imaging because once pregnancies result in miscarriage, even with any imaging, taking into account any imaging or radiation exposure. And I'm going to skip this for the interest of time. And then we look at treatment, IV in the acute setting, IV TPA versus endovascular therapy. And I've already talked about the idea of gestational age and bleeding in the setting of IV TPA, but when you're considering endovascular therapy, other things you do have to consider is gestational age, sedation. Are you going to use sedation? What are those effects on the fetus? And I say that from an obstetric point of view, sedation should always be used, and you shouldn't ever withhold sedation, just like imaging studies. What kind of procedures? Many undergo, ectomies and cholecystectomies and anesthesia, and so sedation is definitely okay. And then one caveat is looking at fetal monitoring. Are you going to monitor this baby during a procedure? And that's a big question that comes up many times in any number of procedures that are performed on a pregnant woman. And you really have to take into account gestational age, counseling to the family. Some families may say, if we're that 24 early preterm period, we're not going to choose fetal monitoring versus later on in that latter third trimester they might. And you have to decide, are you going to act on that fetal monitoring? Are you even in a position to act? There are some cases or some surgeries where you can't act on the fetal monitoring despite seeing abnormalities, and so that may not be the application to monitor during the procedure. And then low-dose aspirin is completely safe in pregnancy, and women can deliver vaginal by C-section on aspirin, and that's not a problem. But fatal agents have been used safely. Lovenox and heparin we're very comfortable using. We traditionally will use Lovenox during the antepartum period just because the number of injections are lower for the women, and we switched to heparin at 36 weeks because we can easily reverse it. The half-life is shorter, so if she were to go into labor, then we have greater control of the situation. And then warfarin really is reserved for women who are at highest risk of clot, and that really is reserved for women with mechanical heart valves. And the considerations for a maternal aspect from a woman who's had a stroke is really the logistics of labor and delivery. She had a long-term disability that's going to prevent her from being able to go up and sort of push. Is she not going to be able to actually help with the actual vaginal delivery? Do you have to consider, do you need to do an operative vaginal delivery, such as forceps or vacuum, because she won't be able to actually push the baby out? You have to think about her self-care. Can she take care of herself? Is she going to be able to take care of an infant? Does she help? Do they need to consider family support, other services? And then if, mom does not survive the event, then what about the rest of the family, and how does that play an impact with other kids that she might have, young children? Fetal considerations, monitoring during the procedure, obviously, and one thing we have to consider is what are the fetal effects of maternal hypoxia? So if she's had a devastating stroke, if she's found unconscious, and if she has a period of hypoxia, what effect does that baby take? And it really depends on the amount of time that the mom spent in that state. And one of the tools that we use in obstetric fetal MRI in the latter third trimester, that's when we actually are able to get pretty good imaging of the fetal brain and see if there have been any long-term effects of an event that might have happened early in pregnancy. And typically we use that in the setting of twin gestations where they share a placenta and one twin has undergone an in utero demise. But it's something that definitely could be extrapolated to a situation like stroke where a mom has had a prolonged period of potentially with lack of oxygen. Timing and, when timing of delivery, do you need to do an early delivery? Is mom status deteriorating and you potentially could save the baby? And that all depends on gestational age and maternal treatment. Breastfeeding, as we've gone through, is safe with all imaging studies. It's also safe with aspirin and antiplatelet agents as well as any anticoagulant agents such as heparin or Lovenox, and including Coumadin. It is safe to breastfeed on Coumadin. So in conclusion, pregnant women are at increased risk for stroke secondary to the physiologic changes of pregnancy and pregnancy-related complications. The workup is really the same in the pregnant as in the non-pregnant population, including all imaging studies. The same treatment modality should be considered, paying special attention to gestational age and the risk of bleeding. All medications are safe to use during pregnancy. That's what we talked about during this talk.
we have another discussion point, and I see some questions here, one that we should probably address. It says, if the patient is already on anticoagulants, for example, in the case of, I'm sorry, I can't read that. You don't read that?
I think it's antiphospholipid antibody syndrome.
Phospholipid antibody syndrome or mechanical valve, should proceed with thrombolytic therapy. Think about that, Mark.
What the guidelines would say is no. If they're already taking an anticoagulant, there's numerous studies in the literature showing that giving them systemic IV TPA does increase the risk of bleeding. So I would opt for endovascular therapy, as Dr. Pride and Dr. Novakovic have talked about, in getting the patient to a facility where they can do endovascular therapy. That's a perfect where I think endovascular therapy would be the preferred treatment approach.
And then with that, and we would, if the INR is above 2, we would probably reverse it in some fashion, and we'd probably just do the endovascular procedure if it's below 2. We just go ahead and do it. Some other questions that have come in. Are there any patient positioning considerations during angiography, especially during later term pregnancy? That's a great question, actually. And it has to do with how you're going to affect time. So you're balancing the risk to the patient, how you're going to affect the time of your procedure. And so there's such a time pressure to get the vessel open, and no outcomes are sensitive to time revascularization. You have to really balance those two things appropriately. And I don't really have a good positioning paradigm for a late pregnancy patient because I've done so few of them. I say there are not major considerations. How about from an OB-GYN perspective? Could you think of any position perspective considerations?
I think really the biggest things that we take into consideration when you're talking about later third trimester is really you want to be off the abdomen, so you want to try to be supine, or if you're going to be prone, any procedure requires prone, you try to use a table with a cutout in it, and in some sort of a left lateral tilt if possible, and that really usually just requires placing a small bump, and it could just be a pack made up of a few laps or towels that you just place under that right side of the abdomen to try to get that uterus off the IVC. Now that changes, affects their ability to, the catheter, then, the procedures that have been done completely supine, I think that's okay too.
I think it would be very easy for us to put them in a left lateral position, and that makes a lot of sense because I don't think that would slow us down at all. Some other positions might be more difficult for us. I mean, just a slight left lateral position.
Correct, just at the hips would be sufficient. The other thing to mention is we will commonly put lead shields both on the back and in front of the patient.
Right, and we do for this patient. Do you have some other questions up there that are new? What use of TPA in the postpartum period, particularly if there's been a cesarean section?
So C-sections are definitely probably one of the more bloody operative procedures, and typically, blood loss is about 1,000 cc's. But I will say that I think most of us would not leave the OR, or I don't think anyone really would leave the OR if the patient wasn't hemostatic. And I think that if you're talking about stroke and needing to treat with TPA versus some bleeding at a C-section site, I think TPA would be okay in that setting, assume that you felt comfortable, you were pretty hemostatic when you left the OR. Typically, we use Toradol post-op for pain without even thinking about it, and we actually give it in the operating room before leaving the table. So I don't think that would be...
Yeah, I think it depends on the time post-delivery and stuff, because, I can share with the group, I had a patient who was post a nose job, nose fix, and the surgeon there and promised that the patient was hemodynamically stable and hemostatic. And I said, okay, if you really want to, and I made the surgeon stay in the room with us, and this was the next day after just a nose job, an uncomplicated nose job, and he full dose systemic TPA because that morning he had a big MCA stroke. This was before endovascular, we didn't have much else to do, and he pulled units of blood from his nose, just from a nose job. So do not underestimate the potency of full dose systemic TPA. In that case, I would really offer endovascular therapy, to be honest with you, only for 6 weeks. Post-surgery, because it's significant, the bleeding risk.
Do you have any other questions come up here? Let's see. Are there verbal questions anyone would like to ask?
Star 6 to unmute your line to ask any questions.
I thought I had one question. I have a question for the group. It's a very hot topic in the stroke world with the new evidence for the effectiveness of endovascular therapy for large vessel occlusion, the appropriate destination for that patient. And are there any thoughts about what the most appropriate destination for a stroke patient would be? Pregnancy just counted something that should get them, they should take into a comprehensive stroke center directly? Is that something we should think about? Or,
you know, one of the definitions of a comprehensive stroke center is that they're able to take care of complicated stroke patients or stroke patients with major systemic disease. And being pregnant in and of itself would fill the diagnosis or criteria for either complicated or having systemic issues. And because of the issues we talked about this afternoon, I would say that if EMS knew that they had a pregnant patient and they were really confident that it was a stroke going on, my advice would be to take them to a comprehensive stroke center, because you need multiple levels of expertise: vascular neurology, interventional, potentially neurosurgery, certainly OBGYN, and before therapy and certainly post-therapy, post-stroke. You're going to need a very coordinated, well-trained, multidisciplinary team to take care of them. If you knew that, I would agree, first choice would be a comprehensive stroke center.
You all agree?
As well, especially because in young patients like this, the most common etiology is going to be some large vessel occlusion of their symptoms.
Right.
And we're better to be able to treat them than someplace where there's endovascular capability.
And you can't treat them with a large stroke. They may need secondary therapy like decompressive craniotomy, neurocritical care expertise, and you have all that at a comprehensive stroke center.
And I would say whoever asked that question typed it while I was asking it, so we were on the same wavelength. So, other questions that have come up?
I don't anymore. If anyone would like to come off the line with Star 6 to ask a question.
Okay. Well, I think that sort of is about the end of our time. If there aren't any other questions, from the AHA, have you seen any other questions or anything we need to ask?
I don't see any other questions in the Q&A question section. Anyone would like to come off mute, they can do that with Star 6. Just another reminder that all the slides and a recording of today's presentation will be made available. We'll email it out in about a week from today so that everyone can have it. And I think Dr. Pride and the whole team from UT Southwestern for helping us with the webinar today. I know it's been a hot topic that our hospitals have asked us to give them information on, so we thoroughly appreciate you taking the time on a Friday before a long weekend to present for us. Thank you so very much, and thank you for everyone who attended.
Absolutely, and thank you for allowing us to take part in this.
Great. We'll go ahead and end the webinar for today. Thank you, everyone, for attending. We appreciate it. Have a good weekend.
Bye-bye. Bye-bye.